Good evening, everybody. My name is David, and welcome to another of the ACPP webinar series and the continuation of a regular set of PD opportunities that the college will be running. Before we begin, I'd like to acknowledge the traditional custodians of the lands where my Australian-based colleagues are located today and pay my respects to their elders past, present and emerging, for they hold the memories, traditions, cultures and hopes of Aboriginal and Torres Strait Islander people. In recognition that we are a binational college, I take this opportunity to acknowledge the Maori as Tangata Whanoa and the Treaty of Waitangi partners in Aotearoa, New Zealand. This evening, I have the pleasure to introduce you to our guest speaker, Aaron McNeill. Aaron is an experienced paramedic and a current physician's assistant, and he works full-time at the Sunshine Coast University Hospital. Aaron is one quarter of the successful Free Radicals podcast and has a passion for education and mentorship. Aaron has a passion for complex medicine, and today he'll be talking about uncommon abdominal presentations. At the end of the presentation, there will be a short Q&A. So if anyone has any questions, please write them into the comments section, and I'm happy to go through them in the order that they appear. Without anything further, Aaron, I'd like to pass the webinar on to you.
Yeah, thanks, David. It's actually really good to be doing something with the college, and also had the opportunity to actually dust off the mic once again. It's been a few months, but really glad to be here. Like Dave was saying, I've been a paramedic for probably the last 10 years in my career, and just currently in the last few months last 6 months, I've transitioned to becoming a physician assistant out at Sunny Coast ED. And my primary role there is basically to do a rapid examination and planning assessment for patients. So I'm still in that sort of acute realm where you need to quickly identify and then get patients pathway through the hospital. So I guess I can probably still speak to a few things that a lot of paramedics still deal with when it comes to abdominal presentations. But hopefully today we can sort of just go through a couple of things I'd like to highlight when it comes to specific presentations. So let's get into it. So I thought I'd just quickly go over the approach, because everything that we do, we don't actually have someone who has appendicitis and we're approaching appendicitis. We're approaching someone who has an abdominal complaint, and whether that's either in the acute or chronic phase. And we have to remember that that acute phase of abdominal pain can be anywhere between 5 to 7 days. Now, what we actually need to do is devise what do their signs and symptoms say about the abdominal pain that they've actually presented with. So are they vomiting blood? Is there blood in their stool? Is there an alteration of either of those two? What are their pain characteristics? And then we measure this up, obviously, with a vital signs survey, and we'll get to why that's important in just a moment. But then the thing about an abdominal approach is that the exam is really rich. Putting your hands on someone's abdomen and actually assessing it does give you a lot of feedback to actually what could be happening. In fact, with the history that you get plus the exam will give you about 2/3 of what pathologies are happening under what you unveil. So like when we talk about peritonism or masses. And then obviously we need to then correlate this to the person's like sex and age. So if we've got a female of childbearing age, obviously we've all been taught it's an ectopic until proven otherwise, but there are some other things like ovarian torsions or intermittent torsions. And we've got things like cyst accidents as well. And then we just need to sort of think, okay, well, does this correlate with their age? Obviously, the more advanced our age is, more things can happen to us. So building this, I guess, this picture really actually allows us to really kind of put a lot of pieces together and form that puzzle piece. Now, a lot of times when we come to people saying, oh, we've got an abdominal pain, this is an abyss. But let's kind of like take it back a step and make this a bit, I guess, simple when it comes to red flags. So do they have excessive pain? Is it severe? It woke them up, or they're writhing in pain, or they don't want to move because there's so much pain? Is there the presence of any examinable features that we can find? Is there are their vital signs altered, or do they have orthostatic changes? Are they just old? Remember, 1 in 70 of every male over the age of 70 is going to have an aortic aneurysm, whether they know it or not. What do their vital signs show? What can we find on their examination? And then do they have some obvious things like jaundice, distension? Have they had previous history of surgery? Or are they a vascular path and they've got significant cardiac history? And maybe this is more to do with the vessels or like the clotting or blood flow to the bowel that's happening at that time. So there's like I said, there's a lot actually going on. But the key to all of this is that history is always going to be king. 80% of formulating that diagnosis will be because of what they actually tell you. And then we marry that up with the clinical exam, we should be able to have a fairly decent provisional diagnosis and differential because we've isolated some local peritonism, we found a mass somewhere, and we've gone, well, you've got this history and that exam equals X, Y, and Z. It's similar to when you think, oh, okay, well, you have a young male who just says, for the last 24 hours, I've just had like this sort of like weird sort of pain up in my stomach. I felt nauseous. I don't want to eat. I haven't eaten for 24 hours. I've had a fever and now it's gone into my pelvis. And you're thinking, okay, this is a classic appendicitis. Put your hands on them. They've got rift rebound tenderness. And that's pretty much most of your diagnostic stream done clinically to say this is appendicitis. And then it leads you down the path of, okay, well, what do I need to order? What can I order? So do I need bloods? Do I need imaging to actually formulate this diagnosis? And in the ED, I just can't have someone come up to me and say, oh, I've got abdominal pain. I'm like, okay, cool. Well, let's do cultures, let's do bloods, let's just do imaging, and let's just see what happens from there. Because nothing's really that specific when it comes to just ordering tests. So our clinical acumen is so important when it comes to this topic. Okay, so like I was saying before, actually, I might just backtrack just one last time or one time. Abdominal presentations basically make up the majority, or is one of the highest presentations to emergency departments and to ambulance as well. Okay, of that, 10% of them are going to have a life-threatening cause or severe cause. And of that 10% of those will have a severe life-threatening illness. So, 1 in 100, that's a quite significant cause. I can think of probably 120 chest pains I've gone to and never seen a STEMI. So the fact that one of these presentations will be really serious should start to like really, bubble some things to the surface that we need to look out for a lot more. All right, I digress. So let's talk about a few things that we might see as a red flag. And the one I want to start with tonight was jaundice. Now, the thing about seeing someone who's got yellow eyes or skin is we really want to knuckle down on how long this has been going on for. So if it's acute and sustained, there's a few other things we need to sort of make sure of, because obviously this is coming from a hyperbilirubia. Oh my God, I'm not even going to say that again. That we've got so much bilirubin in the blood that it's now spilling out into the tissues. And that can either be prehepatic, intrahepatic, or posthepatic. And it's the post that I'm really going to talk about tonight. So if they've got a high history of alcohol intake, their urine and stool has become pale or discolored, and they've got a new itch, I want you to start thinking, okay, could this be, the head of the pancreas around the sphincter rodi, it's the biliary tree, and where is that obstruction happening right there? But the one thing I want you to sort of think about with these patients is, do they have a fever whilst they're jaundiced with right upper quadrant pain? And my mind straight away just goes, I need to rule out that this is acute cholangitis. So with this disease, this is a bacterial infection of the biliary tree that leads to obstruction. And like it says on the slide, 50 to 75% have Charcot's triad, which is that fever, jaundice, and right upper quadrant pain. This is a life-threatening disease. It will lead to sepsis, multi-organ failure, and shock. It's also accompanied by electrolyte derangements, dehydration, and renal failure. The other sort of pearl in this is that in older populations and people who are taking like long-term glucocorticoids, their only presentation might be hypotension. So we really want to gather that history of what they've previously had, and if they've ever had their bile ducts stented as well, or if they've had their common bile duct, their gallbladder actually taken out, where there might be some evidence of they could have an infection going on there at the moment. So like I said, it's a fairly serious disease. There are a few things we need to sort of take into account. This is quite rare. It's not going to happen every day. And typically, they'll have similar symptoms to people who have acute cholecystitis, a biliary leak post-operation, or acute pancreatitis or a liver abscess. So when we're working this patient up, the thing is that they need to be in front of a interventional gastrologist or IR, so they can actually attain an ERCP, which is basically a camera that goes down to have a look at the biliary tree to make sure, to see actually what's obstructing it. Now we can do a magnetic resonance CP, which is again just like an MRI of that local area to see what sort of flow obstruction is going through the biliary tree to make that diagnosis. And then we just want to complete this picture with a set of laboratory tests, which includes sort of like a full blood count, your electrolytes, a metabolic panel, and then some synthetic function of the liver, just to make sure they're not trending towards severe illness, such as your prothrombin time and PT ratios. Okay. Next big cardinal thing that I'm sure most paramedics have actually seen if they've been in the job for more than 3 days is PR bleeding. And I'm sure a lot of the time we get these jobs and we're like, okay, well, what do we really do with this, right? But there's 3 types that I really want to talk about. So there's minimal blood, bright blood per rectum, and that's really our minimal sort of kind of PR bleeding that they'll tell you that, oh, when I wipe, there's some blood, but then it goes away, or I've seen some blood on the surface of my stool. Please ask them if they've taken a photo or get out a fecal color chart just to make sure that what you're identifying is small amounts of blood, because this is generally kind of benign in the most sense. Like these presentations are to do with hemorrhoids, fissures, polyps, ulcers, proctitis, can be with diverticulitis and cancer. There are some red flags we need to be concerned about. So if they have these symptoms plus a postural BP drop, anything that is suggestive that they have melena or a cancer history should be basically worked up very thoroughly straight away in an emergency department and is likely going to get admitted. But if you have the opportunity to do it, or if it's available in your practice, whether you're rural, remote, or wherever you're working as a practitioner, do a fecal occult blood test. Okay, so just remember that when you're doing a digital rectal sweep, that you want to make sure that you're not hitting any fistulas, because that's one way to lose a finger and cause a lot of trauma and more bleeding and probably a significant infection. But the pearl with this is that with an FOBT, hemorrhoids won't affect this. So if that FOBT is positive, then there's something more sinister at play and you need to sort of dig a bit deeper. Okay. When it comes to hematochezia, this is what when people are telling us this is bright red blood passing through the rectum. And the concerns here is if they have if they're of advanced age, their vitals are abnormal, they have orthostatic changes with their vitals, they might have a comorbid background, they say they tell you that it's continually going and there's evidence of that, they're anticoagulated, or you've done a blood test and those tests have come back for whatever reason, and you've got signs of anemia, their blood urea nitrogen levels are out of whack, they've got a raise in their white cells, and their albumin is low. That is a serious complication. And we're trending more towards GI bleeding and vascular causes like ischemic colitis than anything else. The other thing that you need to sort of have a look at with these patients is, are they non-tender and do they have any signs of diarrhea? If they're not tender and they don't have diarrhea with hematochezia, then that's a real red flag, and we need to sort of dig deeper, because this is probably your vascular path patient that now has ischemic colitis and is just bleeding through their bowel. I'm not really going to spend a lot of time on melena, mainly because I think everyone, or at one stage, everyone's had the pleasure of smelling melena. The only thing I would like to say is that when people say that I've got dark stools, just clarify, is it jet black? If it's not jet black and it's just a bit dark, it's hard to differentiate, because then you're just thinking, oh, that could just be diet. That could be a lot of things. But if it's jet black, that's definitely a bleed and we need to be concerned. But where I want to take this with PR bleeding is in our young patients, particularly because we're seeing way more Crohn's and ulcerative colitis, because we're getting just so much better at identifying it. But when we think about how these two present, and we usually grab these patients between that 15 and 30 years of age, but Crohn's typically doesn't present with a lower GI bleed. It's not really a common sign at all. Typically, what we're seeing is inflammation of an unknown cause with those skip lesions, and they've got this typical right lower quadrant pain, a palpable mass in that right lower quadrant as well, because their cecum is just so inflamed. And they've got a history of weight loss, kind of like that failure to thrive picture. But more importantly, their first presentation is usually a perianal abscess or fissure. And then we start to lead down the track from there. Whereas with our ulcerative colitis, this can just be made clinically. 4 weeks of bloody diarrhea. So if you want to picture this in any fashion, or think about the sewer pipe just pushing out and it's just like chalk is red. That is literally what they're doing 6 to 10 times a day, and it just won't stop. They also have a lot of fecal urgency, so they want to get to the bathroom quite a lot. But also they have that feeling like they're not getting everything out. So they've got that feeling of tenesmus. But a quarter of these are going to experience extra intestinal signs and manifestations as well, like uveitis. They'll have erythema nodosum to their peripheries, and some poor souls will also get pyoderma, gangrenous rashes as well. So we just need to be diligent. Chronic diarrhea for more than 4 weeks just needs an exclusive workup, especially when it comes to their hemoglobin levels, their electrolytes, and just to see if their LFTs are actually, or their liver function tests are deranged, because that might steer us in a different direction as well. Imaging for both of these is pretty benign. It doesn't really do anything much for us except to just show, oh, you've got some bowel thickening. So like I said before, if you don't have a decent history and not typing up like your findings to present to sort of a Queensland X-ray or wherever you work, your radiology clinic, then all they're just going to say is bowel thickening consistent with X, Y, Z, 1, 2, 3, because there's just so many different causes. The thing I want to mention though with both of these is when it comes to flares. So with ulcerative colitis, if anyone has that history and tells you that they have this disease, and they're now telling you that they're having more than 6 bloody motions per day, and they have a +1 feature, which is either fever, a heart rate above 90, known anemia, or elevated inflammatory markers, they're in a flare and they need to be in hospital immediately. These patients will end up on blood transfusions and a whole host of other medications that just take a very long time to chase these patients. And it's the same sort of thing with Crohn's, usually not as severe, but typically what ends up happening is they have these periods where they have partial small bowel obstructions because everything gets so sticky. And then they'll require resection and acute surgery as well in these flares. So it's something just to keep in mind. Okay. So the last one I wanted to sort of touch on was distension, because it's one of those things that really kind of, it's visually just out there, for lack of a better term. The beauty about it, I guess, is that we know that there's something is going on. So we can think, you know, they're perfed, they're twisted, they're infected, something is happening there, and we really do need to try and knuckle down on what that is. And the one thing I don't like to miss is a volvulus, particularly because what ends up happening is a lot of people who have a hernia-like presentation do end up having a volvulus. So if you ever have someone who ends up sort of saying they've had hernias before, this feels the same, but then they've got features of a small bowel obstruction. So they're continuously vomiting, maybe it's a lower bowel obstruction, they've got fecal overflow, and they're just generally really tender. That might be a concern, particularly. But what we're talking about here is the bowel just looping on itself and twisting, right? And then causing basically an obstruction. So when you have a smygmoid or cecal volvulus, it's usually quite an insidious onset. So there's this slow, sort of gradual grinding abdominal pain, and then they feel a bit bloated, they get nauseous, they might have some constipation and vomiting, and then they get distension. And that's really at the tipping point where their pain starts to get out of control, and we're now heading towards bowel becoming ischemic. If we want to sort of draw a line in the sand with smygmoid and cecal, smygmoid, you're thinking, okay, people above the age of 70, cecal 40 to 60, but also you might that location is completely different, right, from the riff to lift. So it might just be something, again, where you're like, okay, underneath my hand on this local peritonism are these organs. I need to be thinking about that as well. Midgut volvuluses are much more rarer, and they typically only happen in infants and neonates. And they're going to have those signs of bowel ischemia, so that bilious vomiting, they'll be distended, they're going to look pale, probably a bit shocky as well, and just in extreme colic at that time. So these are all mainly identified through advanced imaging like CT. I think with kids, they sometimes still prefer ultrasound, but they'll usually end up getting a CT anyway because of surgery. But the thing about these patients is that they can go into a paralytic ileus really quickly. And the advent of having a nasogastric tube and fluid resuscitation is really important, along with your IV antibiotics and analgesia prior to surgery. Cool. So the last thing I was going to bring up was spontaneous bacterial peritonitis. So this only happens in patients who either have ascites or they have liver cirrhosis. And it's a really, it's a bit of a nightmare diagnosis, because as soon as anyone who comes in to the ED and they say to me, I have liver failure and ascites, and I'm just generally a bit more sore than usual. I think my ascites have gotten a bit bigger. You've got to make a really quick decision of, is this SBP? So typically what I try to look for in these patients is, have they spiked a fever? But a lot of them are immunocompromised, they might not spike a fever. Do they have any other signs of systemic illness? So fever and chills, nausea and vomiting, or any signs of hepatic encephalopathy. And we should really sort of separate those 4 stages just to make sure that, you know, they're not building up their ammonia and starting to make their brain edematous with this illness as well. But what you'll usually find is that they'll say, oh, I've got pain here. And you go to sort of assess that abdomen, and they're like a gastroenteritis. They just kind of generally tender everywhere, but nothing really sort of syncs up. If you're in a situation where you're not sure, either, especially if you're rural remote, please make a phone call straight away. These patients need to be put on triple antibiotic therapy very quickly, because they will go down very quickly and they are hard to chase once they're there. They have a very extensive workup. It's from all your blood tests being cultures, your inflammatory markers, liver function tests, metabolic panels, their coagulation tests, and a whole host of others. So if you do happen to have that inkling, please make sure that they're also going to a hospital that can actually deal with either hepatology in that way, or they've got at least a general surgery unit. And that's pretty much all I'm going to go into tonight. I think to summarize all this up though, you know, it's the one thing I keep hearing, or I've heard in my career, right, is that it's abdominal pain. It's really hard to identify, except for it probably isn't. If you invest that time to actually get a really good history, and remember, like, you've read the book, they haven't read the book, so you should be able to put their words into medical semantics to enrich what they're actually saying to you that makes logical and reasonable sense to their individual physiology. And then if you spend time practicing that exam, you get better and better and better, to the point where you'll start to identify common illnesses really easily, particularly when it comes to things like colitis, renal colic, biliary colic, gastroenteritis, torsions, you name it, diverticulitis, appendicitis. These things will just become like second nature. But it does take that little bit more effort just to zero in on what they're saying and what you're actually feeling for as well. So thank you very much for listening to me ramble for the last 25 minutes. And hopefully there's something you get out of it and use with your practice.
Oh, that's fantastic, Aaron. Thank you so much for that. That was really, really interesting, actually. I had a patient recently myself who had suspected SBP recently, and it was really interesting to follow him up over the few days afterwards. Are you able to see my video by chance, Aaron?
Yeah, I can see.
Okay, good. I can't see it on my screen for some reason. We do have a couple of questions already, so I might just get through them.
Sure.
Coxie has gone and sent a few. I'll start off with your second one, Coxie. So ultrasound. And the question is, do you see any benefits in the triage area that you find yourself in at SCU, Sunshine Coast University Hospital?
So I think anyone in the emergency space, whether it be in hospital, out of hospital, can attest to ultrasound is coming. And handheld devices and POCUS, so point of care ultrasound, is definitely coming. Unfortunately, at the moment, I don't think the technology is there to identify serious illness, and I probably don't do enough at the moment to, find an appendix or those obscure sort of pathologies. But doing a Murphy sign test with someone who you think this is a dog's balls for cholecystitis or gallstones, yeah, absolutely. I honestly think we should all be carrying one around rather than stethoscopes, if I'm being frank. But it will come down to like, how much do you use it? How competent can you really be with it? And how good is the technology? And does the AI in those, in that tech actually help you out as well? But still, you know, even if we do identify anything, they need a formal outside the realm of a rupturing AAA or someone who's got who's bleeding into their bowel from something, and you can just identify fluid.
Bacterial peritonitis in the remote field. And do you think there's a possibility, or what is your view on IV antibiotics as an initial treatment or prophylaxis? So the way that I'm interpreting this question from Coxie here is, you're not near a hospital, you're quite remote, you're suspecting a bacterial peritonitis, and the role of early IV antibiotics in the treatment of that patient.
Yeah, if it's available to you, it's probably a reasonable start. But I think you really do need to get onto the phone to the receiving hospital. Say, and sorry, Coxie, I don't know where you're coming in from, but let's say it's like Broken Hill and you're in New South Wales, and you're going to be, they're going to get airlifted to Manly North Shore, and I don't know why, but and that's where they're going. I think it's a call to that hospital first, just to say, hey, this is what I'm concerned about, and have that chat with, you know, your gastrointerventional reg or consultant. And I think probably the majority of the times they'll say, yeah, start triples, because of the extent of delay that's going to happen between where you are there and then as well. But if you've got if you think you've got a good history for it, yeah, I don't see a problem with it.
I'm interested, Aaron, myself, in discussing the role of paramedic practitioners in the primary healthcare space, and how, you know, as you've mentioned before, very early on, abdominal presentations are quite common in the ED. They're also very common in the primary healthcare space. GPs see abdominal pains every day, and I'm interested in how a paramedic practitioner, let's say working in a remote field or a rural area, may be able to do some key tests locally before having to refer on to an emergency department. Obviously, we have our red flag signs, but do you see a role for urgent medical imaging, blood pathologies, and some key diagnostics in the primary healthcare space before referring on to an ED? Or do you suspect that the workup is best done in an emergency department's environments where possible?
Yeah, I wish there was a black and white for this, but, you know, like, we're already doing it every day, aren't we? So in your primary healthcare field, you have doctors and nurse practitioners, and I'm sure paramedic practitioners in the future, already seeing all these types of patients and sending them for either urgent or non-urgent investigations, depending on what their clinical acumen actually tells them. Okay, and you know, sometimes things are going to slip through the cracks, and that's just life. But I think if you're adept of you know, knowing that patient, and you have a good suspicion that you just think, oh, this is not actually a serious complication at the moment, I just think this is like routine uncomplicated diverticulitis, I'm going to send you for a scan. Or you know, you're not too sore, your presentation isn't really typical, but I'll send you for you know, like an ultrasound for whatever that reason is. I think that's perfectly reasonable. It's the patients where you kind of, you know, yourself, you've eyeballed them, gone, there's something not right here, or this is, we really need to exclude this major cause, and that has to be done today. You know, the patients with PR bleeding, you know, if they've just got the minimal bleeding, which is the majority of presentations, they have a mortality of less than 0.8%. So it's, you know, there is that safety net there. And if you get a blood test back that day that goes, hey, the HB is 130, you're like, okay, well, I'm not really bleeding at all. Or if you have the ability to, you know, do a gas, maybe you're working in a a rural area that has, just limited diagnostics like an ISTAT, then that's perfectly reasonable. I think it's just one of those things that as you get more experienced, you realize what is, what can stay at home and what should be going to hospital. So trust your learning.
Good. Well, Aaron, I wanted to say thank you again for coming on tonight. That was a really, really interesting talk, and something that I'm sure is going to get a lot of views moving forward. Abdominal presentations are complicated. These uncommon pathologies that you were talking about, I think it gives us all some more food for thought and understanding of the complexity of that. And again, for our primary healthcare paramedics, this is going to be a large part of their job. So it's just a fantastic opportunity to speak to you and lean on your experience with that as well. Aaron, thank you very much. Everyone, thank you for joining us live here today. This video will be uploaded onto YouTube some stage over the next 24 hours, I hope, pending any technical issues on my end. Thanks for joining, and we'll see you all at the next webinar. Take care.